We're going to talk about, and luckily revisit stuff you've already been tested on and seen, which are still the mainstay in some of the headache disorders, i.e. we're going to talk NSAIDs, Tylenol, but then we're going to talk about some new targeted monoclonal antibodies and injections and the triptans. So not a lot of new medications today, but definitely some that are very targeted for specific disease disorders related to headaches. So we're going to talk about the three primary I just mentioned, and then we're going to talk about how to kind of put them in a bucket as far as migraines, cluster, and tension headaches versus headaches that are secondary to other underlying causes, which are outside the scope of what we're going to talk Pharm, because then you got to investigate numerous causes for headaches that are not primary, i.e. headaches that are related to some different underlying disorder. So meds, again, discussed in the lecture, a lot of repeat offenders on the list, and then we're going to talk specifically the triptans and the CGRPs, which are kind of new, and a lot of the others we're just going to revisit and continue. Long list, but you've had a lot of them. This is not a memory list, right? You just use this for studying, just like I mentioned about gout and rheumatoid arthritis. When you get lost in the sauce, you can refer back to this list and say, okay, what class am I in? What are we talking here? So headaches, primary, are going to be your migraines, your tension, and your clusters. Migraines, we used to talk about classic versus common. Now we just say with aura or without an aura. And i.e., we'll talk about what auras are, but some precipitating foreshadowing of a headache's coming, right? Changes in light, perception. So we'll talk about what that is. But when we say aura, migraines now, we say with or without. You will see sometimes still referred to as classic, meaning there is an aura there, that you have these precipitations of this senses change to the point where you know a headache's coming, versus previously common is without that aura. Now we put them in that bucket of their migraines with or without. And there are some specialty classifications within migraines. That's outside the scope, right? You'll get that in neuro. Major McMahon will talk to you about like basilar migraines and specific types of migraines. But here we're just going to talk migraines, not subdivide them out other than with or without an aura. And then secondary headaches are related to something else, as I mentioned. And we're going to give you an acronym coming up here, how you can put them in a classification to know whether, hey, do I need to start looking before I start treating with labs or some imaging, meaning they're secondary, versus one of these primaries, we go right into treatment, right? We classify them and then treat them, but when we have secondary headaches, we have to look for the underlying disorder first. That's the big difference. Numerous causes for secondary. Some are on your slide: infection, trauma, some hemorrhage, like subarachnoid hemorrhage, worst headache of my life, or a thunderclap presentation. You'll get a lot of these secondary causes in neuro or in trauma, whatever the underlying disorder may be. So this is important. Know this acronym. It's not going to show up on your test like what is POUND or what is SNOOP. This is to help you classify primary versus secondary headaches, right? So POUND, we're going to say this is related migraines, right? We're going to classify migraines. They're pulsatile. Usually they're about 1 day in duration. They're one-sided. They're usually associated, they being migraines, with nausea and vomiting. And they're often disabling, right? You're going to see this patient not doing anything. They're going to be in a dark room, kind of laying over, clutching their head probably. They are out of commission. They're not functioning. And if you have 3 or 4 in the POUND acronym there, then that's strongly suggestive of migraine. If you use the SNOOP acronym to classify your headache, and it's showing up with systemic symptoms, any kind of neurological defects or deficits, if it's a sudden onset, or if it's that older age onset, meaning over 50 and this is the first time this has happened, or any change in a patient who may be older or younger, but they've had headaches in the past, but now they're different. significant change in those headaches. So the big exam trap is listed there. If the SNOOP acronym helps classify the patient presentation, you need to investigate that first. You don't go right into treatment. If the pound criteria are there, then it's more than likely migraine, and then we're going to get into how we manage those, right? But if you have any of those other red flags, you need to do some investigation first. So here is just an algorithm. You see on the top right, we're saying our patient presents with headaches, and if the SNOOP acronym helps us classify it and it's not falling under the pounding acronym, then we need to consider secondary headache diagnosis, something else causing it, and we refer or work up what the underlying condition may be. If it follows the pound acronym, we're going to treat it as a migraine. And then you'll notice for all of the primary headaches that we'll talk about today, migraine, tension, and cluster, pay close attention to acute/abortive therapy. How do we control this patient's pain and headache signs and symptoms now? And then according to the different primary headache classifications, for each of those, we're going to talk about if we're having this type headache, meaning one of the three primaries, more than X amount of times per month, or if we're having headache days, because some headaches can last multiple days, times X many days per month, then we're going to look at how can we get after this prophylactically to keep the headache from coming, right? So treat abortively or acutely, and then how can we use some prophylactic medication to prevent it from happening if the patient meets the criteria for it. And we'll talk about those. Migraine triggers, lots of them, right? PA school, big one. Why? All the caffeine, lack of sleep, the stress, all those things, yes, can trigger migraines. And there's a whole list there. I mean, hormone fluctuations, females can get menstrual-related migraines. That's a classification too. But really, anything that's stressful, taxing on our system. So we're going to jump right into migraines. Acute migraine treatment, right? So 2 distinct goals for acute treatment of migraines. These acute or abortive agents stop the migraine if it's already in progress, i.e. why your patient's there, right? I'm here because this migraine headache is killing me, so we want to stop it. And then we want to get that pain relief very rapidly, restore them to function, and minimize the need for additional medications, right? Because we'll talk in a few slides, if you continually use certain medications, you can actually cause headaches to worsen. You can have a medication overuse headache, and we'll define that in the next couple of slides. So we want to get them functioning. We say 1 hour, right? But we want some pain relief within a couple of hours. And often when we use targeted medications like the triptans for migraines, we can talk about, hey, when do we repeat the dose? 2 doses max, but some we can repeat in as little as an hour, some in 2 hours, a couple in 4 hours. But we want to get maximum pain relief as quickly as possible based on what agent we're using. And we want to use medications that have the lower side effect profiles. So common sense, right? Do the best for the patient with the least amount of adverse effects. And we want it to be affordable. And then as far as long-term goals, as our second goal for migraine headaches, we want to reduce how often the patient is getting migraines, how long they're lasting, how bad their disability is when they do have migraines, and then we want to prevent them from coming on, right? And once again, keep their use of the abortive agents, the acute agents, to a minimum. And a lot of this is educating our patient as well, as on the last bullet. So treatment, very individualized, right? What works for one patient may not work and could worsen the headaches in another patient. So it's very individualized treatment, but we're going to give you kind of an algorithm to follow, but just know that sometimes we have to shift gears and adjust based on how our individual migraine patient responds. So successful medication response, we hope within 2 hours, and their pain's reduced. couple of key bullets, and we're going to talk about them more later, but those bullet number 2 and 3 there, important concept, right? If they don't do well with NSAIDs, try triptan. And then we can add an NSAID if patients don't do well with the triptans. And we'll talk about that treatment algorithm, but that one's going to show up a bit. And then the new one you probably never heard of, or maybe if you're a patient who has migraines. So CGRPs, so calcitonin gene-related peptides. Those are the new kids on the block, and we'll talk about what they do and why we utilize them. But we can use CGRPs, both a couple of them for abortive and most of them for prophylactic treatment for migraine headaches. There are some migraine indexes, or basically score sheets, tally sheets to discuss severity. I'm not going to ask you about them. On almost all of them, the higher the score, the more points, the more severe, the more disabling they are. The MIDAS, the first one listed there, the Migraine Disability Assessment Index, that's the one you'll see most common. I'm not expecting you to know, but just know that they exist in our universe, right? Those algorithms basically to assess the effectiveness of our medications. And like I said, almost all of them, the higher the score, the more severe the headache and less responsive to medications they're going to be. So migraine treatment, we're going to always talk non-pharmacological like we do with many disease processes that we discuss in Pharm. Hey, lifestyle changes, what can we do, right? Well, we had the slide of triggers. We're obviously not going to avoid PA school, but we can avoid lack of sleep, maybe, right? Decreasing our caffeine, hopefully, but avoiding some triggers, non-pharmacological treatment. So if you can identify for your patient, or the patient keeps what we call a headache diary, right? What was I doing when I got a migraine last time? Okay, this time I was doing the same thing, eating the same thing, same kind of scenarios were going on. So headache diaries often help with avoiding those triggers because you have to identify the triggers to avoid them. Ice to the head, common sense. My head hurts, put some ice on it. It's kind of intuitive. Rest in a dark, quiet environment. I will tell you that when you see your migraine patients, they're going to insist on a dark, quiet environment. They come in to see you at your clinic, on your aid station, and the first thing they're going to do is ask whoever first comes in the room with them, hey, can you dim the lights? Can you shut the door? Can you talk quietly? So patients are going to do that, once again, kind of intuitively, because those sounds and the lights can make their headache worse. It aggravates it. Get them on a regular sleep pattern, exercising, dieting, smoking cessation, reducing the caffeine. So all the things that we talk about that makes things worse, we want to clean up their lifestyle. And we can also use some behavioral interventions for migraines, i.e. biofeedback or relaxation therapy to help with their stress. So this slide is from the 2023 VA DoD CPG, i.e. who we work for, right? Our boss is the DoD. This is what they say, and I put it up there just to show you the framework for what they recommend for acute pharmacological treatments. I will tell you that when you see these slides, they're not exactly what we're going to say is first line. You may see some weak 4 by the DoD, but we're going to tell you, hey, this is first line. It may be weak, but it's the best we got, right? As far as the DoD is concerned, though, this is what they say is strong for and what the evidence is weak for. On the bottom of the slide there, abortive therapy, and all these are abortive treatments or acute treatments. Those GON blocks and SON blocks, you guys know what those are? So specific nerve blocks they can do. I think the GON is greater occipital nerve. SON is what, supratrochlear, I think. So just a couple of nerve blocks that can be done that can help. But I will refer to this, but you need to know what I say is first line, second line, third line. I wouldn't pay a whole lot of attention to the strong 4 or weak 4. Interestingly, though, if you look at recommendation number 22, rimogepant, ubrogepant, those are those CRGPs that we mentioned, right? They're the oral small, and we'll talk, there's some injectables, and then there's some orals. The pants end those are the orals, the one that have pants at the end, and we'll talk about them, PANTS. And then the other ones are our old friend MABs, so they're easy, right? It's a monoclonal antibody. It ends in MAB. but we'll get there. But I pointed out that the DoD and the VA do recommend those newer lines of medications, especially for prophylaxis, right? The CRGP antagonists. So acute treatment, abortive, stop it. Our old friends, our analgesics, right? Tylenol, NSAIDs. We beat them to death. You know what they do. You know the contraindications. You know which one is liver toxic, which one doesn't work in renal disease, right? Everybody knows that at this point, or at least you've seen it a few times. You might not have got it right, but you've seen it and you've been given the information, right? So we can start there. I will tell you that those analgesics, very mild pain, yes, they may help. People may find some over-the-counter combinations of analgesics that may help. Usually that's kind of that mild to moderate. We're going to probably, well, we are, and you are, moderate migraines, you're going to get to a triptan, hopefully. Well, it'd be great if they were controlled just with either Tylenol or NSAIDs, but the data says no. Usually we're going to go to the middle bullet there, specific therapy, the triptans. We'll talk about what they do. And then there's an old drug, ergotamines, which have a lot of side effects. That before triptans, we used them a lot, but they're very dangerous drugs, I would say. I would even go as far as to say dangerous, especially with certain underlying conditions that we'll talk about now. And then the miscellaneous agents, we're going to talk about Stadol, butorphanol, controlled substance. We're going to talk about why you never use it or shouldn't be using it. And then we said migraines often include nausea and vomiting. So some of these drugs are going to come back from sophomore semester GI drugs, right? So antiemetics. Hopefully you remember that. Well, you guys haven't had that long of a time, but hopefully in a junior classroom you can remember it from sophomore. But I'm sure you've seen those the antiemetics in a few of your ologies by now too over in the junior classroom. All right, medication overuse headache, critical concept, right? Because you have a headache, you take meds for the headache, the meds that you're taking so often give you a worsening headache. So that's why we try to do targeted therapy, and we talked about decreasing the amount of drugs or the abortive therapies as much as possible, getting our patients, if they meet the criteria, on some type of prophylactic treatment to decrease the frequency of their migraines, which in turn means less use of those acute abortive migraine medications. How do we treat medication overuse headache? We get them off of the medication that they've been taking too often, right? Right there in the middle. Treatment for medication overuse is to discontinue the offending agent, unfortunately. Take them off of it and then we go to something else. You'll hear medication overuse headache called a rebound headache or a analgesic rebound headache. All of them mean the same thing. You've been taking acute abortive medications, and then when you come off of them, you get a headache because you're taking them over and over again. And there's some down regulation of sensors, right? And we'll talk about what those are, serotoninogenic sensors. But what you need to just know about it is that if you take those abortive agents often, that sometimes you can start getting an overuse headache from having them too often or when you stop taking them. A lot of the ones like the butorphanol I mentioned, you can actually develop dependence because it's a narcotic, right, or a controlled substance. And then you'll see in the middle there, most often with the analgesics, opioids, yes, everybody kind of knows about coming off opioids and how you can develop dependence. But the triptans are a player here too, especially if you're using them very often. A lot of times we'll talk about bridging therapies, but we're getting into clinical management there. So I'll just leave it at, we're going to try different agents after they stop the offending agent that's causing the medication overuse headache. A lot of times 3 to 8 weeks after they withdraw off the medication that's giving them a rebound headache. So this patient's going to have a lot of follow-up so we can find the right agents to put them on. And if we talk opioids or barbiturates and benzos, then we're talking severe withdrawal symptoms, which may even mean go into a facility to be monitored and medicated during your withdrawals. So the take-home point is underlined there for your abortive agents or acute treatments for migraines. We want to limit them to max of 2 days a week. Anytime we're going with even the NSAIDs, but the triptans or any of these classes of abortive agents we briefly touched on already, more than twice a week is concerned for medication overuse headache. So it kind of makes sense. If you're doing something twice a week for months on end, we're starting to get into an area where your body is developing a dependence on it. So the first one, Tylenol, we don't even have to talk about it, right? We've been there. We've done this one. But for acute migraines, 1,000 milligrams is recommended. For mild to moderate, once again, once we get into moderate to severe classifications or increased frequency, we're going to try to get to a specific agent, usually a triptan. And we all know it gives analgesia, nothing on the platelets, and nothing anti-inflammatory wise. So it's weak by the VA DOD as well. So they got that one right. They agree with all the other bodies on that one. So combo, caution on this one. You'll see people do the Furacet and the Furanol, but it has a barbiturate in it. So definitely can develop dependence, tolerance, all those things that come with controlled substances, which the Furanol, which is aspirin, and the barbiturate, butalbital, which is under formulation, the second one, it's a controlled substance. The reason that the Tylenol combination is not, i.e. Furacet, is because do we or do we not have an antidote for Tylenol? Tylenol overdose, we have an antidote. We don't for aspirin, right? So you will see when you're out in practice, if either once you leave the service or if you're guard reserves or you're working in the civilian practice, some states will also make the Furacet a controlled substance. But as you see under bold limited use due to the following, it doesn't work that great. It's a barbiturate and a controlled substance. Potential for abuse or dependence on it, and then withdrawal high for discontinuation. So you can develop dependence on the barbiturate, which is the butalbital in that medication. So just strongly caution against you using this medication for chronic recurring type headaches. So we can have an acetaminophen combo. This is the one you'll see patients obviously go over to, HEB, whatever, CVS. They pick up their Excedrin migraine. It's okay as a first line option. For mild, I would say it's probably a good first line. If it's controlling their headaches, it's okay. The caffeine helps with the analgesic effect of the Tylenol. And you see it's got aspirin, so it's got some NSAID in it, low dose with aspirin, Tylenol, and the caffeine. And the mechanism of the caffeine is listed there. I'm not going to ask you about that, but it does contribute to the analgesic effect. It helps by causing some vasoconstriction. And when we talk about the pathophys of migraines coming up soon, you'll see that's vasodilation. So the caffeine does contribute to a little of that. So once again, we're talking analgesics, not targeted specific therapy. So mild to moderate. And then there's the dosing there. We're not going to ask you dosing, kind of in line with all of the Pharm lectures and tests. We don't usually ask dosing unless it's something that's very specific, i.e. you must take this amount, then this amount. But I'm not going to hit you on dosing for OTC, Excedrin migraine. And you can get caffeine withdrawals, right? So just like if you're drinking it, if you're taking it in pill form, you can get that medication overuse headache when you withdraw just off of the caffeine portion of this, and also the Tylenol and the aspirin. So caution if your patient is taking a lot of Excedrin migraine. So the NSAIDs, another one that we have the t-shirt on, right? Been there, done that. We know what they do. We know that we have some that work in the COX-1 pathway more than 2 and 2 more than 1. But NSAIDs, once again, in that class, anti-inflammatory, mild to moderate, right? First line option, mild to moderate. If NSAIDs have worked for your patient, by all means use them. If they worked in the past and they're not, then move to a targeted therapy. And we'll talk about that scaling up, right? So then probably, just like I mentioned on that common theme, if they worked in the past, you can add a triptan or CGRP if the NSAIDs are no longer working. But if they've worked, then go for it. VA says weak for these as well. which kind of agrees, unless it's mild and they've responded to it first. Not bad to try an NSAID, right out of the chute, but if they're any kind of more than mild, we're probably going to have to go targeted therapy. We do have a limitation use recommended. Anytime you see this in your slide deck, it's important that how we limit the use of certain acute or abortive agents to what, right? So for NSAIDs, no more than 15 days per month to prevent MOH. So we have the limitation of use almost for all our classes. I would pay attention to that as we move through the slide deck. So for NSAIDs, 15 days per month to prevent medication overuse. Now, here's I don't even know who the little guy spinning around is, but he's throwing money, so it's our money slide, right? It's our money slide. Triptans, targeted therapy for migraines, first line therapy for moderate to severe, where most of your patients are going to end up. So what do they do? So they are serotonin 5-HT1B/1D receptor agonists, right? They activate serotonin receptors. Activate serotonin receptors. I need you to know the specific mechanism of action of triptans. 5-HT1B/1D receptors agonist with also some activity at 5-HT1F, but the main thing you need to know that they're serotonin receptors, so the serotonin receptor specific 5-HT1B and 1D is what I need you to remember, and that's what the board is going to ask you about, so probably hint, right? So serotonin receptors are activated by the triptans. If you look over to the far right, it shows the three-pronged attack of the triptans, right? They cause vasoconstriction of the dilated blood vessels in the head. They release they inhibit the release of vasoactive neuropeptides. Hint, hint, from what we already talked about a drug class, one of them being CGRP, right? Calcitonin gene-related peptides, and that's why that's a new targeted synthetic therapy. So they inhibit the release of things like substance P, CGRP, things that cause inflammation and can further vasodilate. And then lastly, they inhibit pain transmission to the brainstem. So that's the far right. That's explaining what our triptans do with the red arrows, right? And then on the far left is showing what happens in migraines. Starting at the top left, you get that trigger, you get below that, the vessels get trigeminal vascular afferent pathways are activated, and then we go over into the spinal cord, and then we talk about getting into the trigeminal ganglion, and we're sending pain up into the brain, and then that explains why the triptan, its action is to prevent that pathway. And then number two there, release of vasoactive neuropeptides from that trigger. Those are those peptides I just mentioned, CGRP, substance P, sodium, potassium A, so all of those neuropeptides that cause vasodilation and increase inflammation. And that's when you look over at 2, and it leads over to the right, showing what happens with a migraine with the vasodilation and increase of those peptides. And then if you follow it down to number 6 there, the parasympathetic nervous system will sustain the vasodilation caused by those neuropeptides, those inflammatory peptides. I don't need you to know all that. I just give it to you as background so that you understand how the triptans work. By binding to those and activating those serotonin 5-HT1B/1D receptors, it counteracts all 3 of those actions, right? So it vasoconstricts because the dilation is what gives you some of the headache. It also inhibits the release of those inflammatory neuropeptides that I mentioned, and then it also inhibits the pain transmission. So everybody clear on that? I mean, kind of a busy slide, but just understand the mechanism of action of triptans. Triptans is the whole point. And if you want to dig deep into the pathophys, it's there for you. What happens with migraine headaches and what triggers for migraines cause to happen in our system. All right, lots of triptans out there. The good thing is they end in triptan. Right? Easy peasy. Ends in triptan, guess what it is? It's a triptan. Yep. There are some minor differences. They're pointed out there for you. The big things that you need to know off of this is that a subcutaneous injection, whether that be with the sumatriptan's the big player here. There's a needle system and then there's a non-needle system, which basically is a dual action. It still injects the medication subcutaneously, but you'll see there that you can repeat those injections in an hour. So they're a little faster acting. So we'll say that sumatriptan out of this class is faster acting. There's also an oral disintegrating tablet that's faster, right, than just pills. Just trying to see if there's anything else major on this summary. It's just the minor differences. The key that I want you to pick up on is the 2 hour. There's also the naratriptan, that's 4 hours. So almost all of them are 2. The subcutaneous injectable and the oral disintegrating tablet, fast acting, which makes sense, right? Oral disintegrating and a sub-Q is going to act faster in our system. So within 1 hour, you can repeat it. Almost everything else is 2, and then the naratriptan is 4 hours. So slower onset, but it lasts longer. And often, and we'll talk about this a little bit, it's more trivia, but we use them in menstrual migraines more because they have that longer action, right? But if you see triptan, it's a triptan. And that means it is an agonist to those serotonin 5-HT1 receptors. All right? Everybody good on that? Yep. Yeah, what were you? Well, it's not so much trivia, it's just the minor differences. You're not going to get tested like on that stuff. All right? You will be tested on some of these drugs. When can you repeat the dose? And there's another slide. So it's repeating itself, so it should be pretty obvious. I'm not going to ask you the fact that naratriptan has a longer half-life because it's not metabolized by MAO, right? And the board won't get that deep on it either. This is just your administration differences, right? The sumatriptan, there's sub-Q, there's the injectable, and then the rizatriptan or the ODT tablets. So the 2 on the far left, guess what? 1 hour, fast acting, right? Because they're oral disintegrating or they're a sub-Q injection. There is an intranasal spray for sumatriptan, and then there's just an example of the zomatriptan tablets. Here we go. Repeating what I said there, right? But in a nice chart. So 1 hour, the injection. 2 hours, mainly all the rest of them, and then that long-acting naratriptan. I don't think that's a heavy lift to know the difference between those. Key is whether it's a 1 hour or a 2 hour repeat dose. Now, if they do well with one dose, you don't need to repeat it. Often we give our patients these medications in our clinic, like while they're there, right? So they're super fast acting. You can do the sub-Q injection, and a lot of times have them hang around an hour. Now we're getting into clinical management, but we do often treat our patient in the clinic with an acute severe migraine. At least try to get them back functioning, right? And then the differences that I need you to know is that no matter which medication you use, whether it can be repeated in an hour or 2 or 4, it's still maximum of how many doses of each medication? 2. 2 doses max. So whether it was at 1 hour or 2 hours or 4 hours, they're done for the day, right? That's the most you can do in a 24-hour period. Everybody tracking what I said there? All right. So no more than 2 doses of any triptan. And I wouldn't go mixing them up, though, right? If you give 1 dose of one, then use the same medication for the second dose if you give it. Now, if they don't respond, now we're getting into clinical management. We can switch triptans, but I wouldn't be playing that game during an acute headache on the same day, right? Still talking triptans. Moderate to severe is the use. First dose, look at that in the clinic. We sometimes, because they are vasoconstrictive, we'll put the patient on the EKG. But they're gonna experience some signs and symptoms of vasoconstriction, and we're gonna talk about in the upcoming slides, because there's where a lot of our contraindications come from. And it's mentioned there, coronary artery disease is one of the big players of contraindications, and there's a slide completely dedicated to it. And then under the administrative considerations, once again, that's just a discussion of why we use some that are fast acting versus a long acting. And then there's a little bullet there, but I'm talking about it on a specific slide. We said, is nausea and vomiting often associated with migraine or not? It is, right? So then we can also treat their nausea and vomiting in the clinic too, usually with something fast acting as well, whether that be a disintegrating tablet, some sublingual, intranasal, or an injection. And we'll talk about which classes are preferred. There it is again, how we limit our triptans for acute abortive 2 days a week, right? About 2 days a week, or 10 days per month to prevent medication overuse headache. So those are important concepts for each of these drug classes. I would know those numbers. So here's a nice chart for adverse effect. They're vasoconstrictive, so your patients will experience some tightness, chest tightness and pressure, right? Head, neck, chest. I mean, when you give these, or if you've ever seen it, give it to a patient, they're like, oh, that feels a little funny, right? I'm feeling a little tightness in the chest. As long as they don't have one of these major contraindications in the middle, that's okay, it's expected. You can get some finger numbness, some paresthesias. They can feel a little fatigued. So if I was giving this in the clinic, I would ask if they had a driver normally before I would do it, right? If they don't, or if I'm a little nervous about their contraindications, then I would say, hey, try it at home. But if they have a driver, you're more safe, right? In case they have some of these adverse effects. Flushing's common, warm sensations. If it's an injectable, common sense, you can get pain where you injected something. And then hypertensive crisis is a serious adverse effect, very rare, but you have to keep it in the back of your mind, right? That's why I said if we do it in the clinic, sometimes we're going to, most of the time, try to get them on EKG just to see what's happening, or at least take serial BPs and pulse, right? But contraindications, you need to know these, right? Do not give a triptan to someone with uncontrolled hypertension, whether that means they have hypertension and it's severe and they've never been medicated or told that they have it, or they're non-compliant with their medications, or they're taking antihypertensives and it's not working, right? They're still, so if they're uncontrolled hypertensive disorder, do not give them a triptan. If they have any past medical history of ischemic heart disease, right? Angina or a prior MI, cerebral vascular disease, like a stroke. What's Prince-Meadows angina? Vasospasm, right? Those coronary arteries. So kind of transient, but if they have a history of that, don't give them a triptan. And those two special classes of migraines, the hemiplegic and basilar migraines. So the basilar ones, you have auras that are like brainstem oriented, vertigo, speech disorders. I'm not asking you to classify them, but there's a contraindication. If you have those subclasses, like the hemiplegic makes sense, right? It presents like a neurological disorder, hemiplegia, weakness on one side. You probably want to rule out stroke before you start wearing triptan, but worrying about triptans, because hemiplegic migraine, they're having neuromuscular signs and symptoms or neurological signs and symptoms with the migraine. I'm concerned about ruling out stroke, but neuro will talk to you more about that, but just know it's a contraindication for triptans. And then for drug-on-drug interactions, we're going to talk ergotamine, very severe vasoconstrictive agent. The old one I said that we used in the past. Don't use it within 24 hours if you do use an ergotamine. It's not very commonly used anymore. There's some specific niche uses of the ergotamines, and we'll get there. Or if you used a triptan, right, within 24 hours. So don't give them another triptan unless you're doing the 1 day 2 dose but don't give another triptan if they've had a max dose within 24 hours. Unfortunately, you just have to wait 24 hours before you can try another agent. So I can tell you that boards love to say everything classic for a migraine, and in the history they're going to say the patient had a past MI or is diagnosed with coronary artery disease, and it's going to ask about giving triptans. Contraindicated, right? Contraindicated. Right off the slides. And just make sure there's nothing else I want you to know. Yeah, bottom right, right? Serotonin syndrome. We talked about what triptans do. Where do they act? They activate the serotonin receptors. So you should know by now, other medication classes, a lot of them in the psychoactive medications, those behavioral health medications, right? So you do have a risk, an increased risk with triptans and anything else that increases serotonin, like the TCAs, SSRIs, it's in the name for SSRIs, right? Or MAOIs, so we should all be familiar with those. But definitely an increased risk of serotonin syndrome with triptans and other serotoninogenic medications, as mentioned, is even on the slide. Serotonin active medications, SSRIs, TCAs being your big players, and MAOIs. And then don't use with strong CYP3A4. We're familiar with those. Anybody remember what are strong ones? Like the azoles, right? The antifungals, and then your macrolide antibiotics, right? Clarithromycin, erythromycin. So you need to know, those show up all the time, the CYP3A4 enzyme, either inhibitors or increasers, but in this case, strong inhibitors or serotoninogenic medications, severe drug interactions. Which leads to serotonin syndrome. Raise hands. We've talked serotonin syndrome quite a bit, right? So we know that cluster of 3 that we're looking for. Everybody tracking what I'm saying? It's on the bottom left. Those cognitive changes, neuromuscular dysfunction. There's the entire list, all you ever wanted to know of those 3 different clinical triads of abnormalities on the right there and the percentages. But what I need you to know is if you're using any of those other serotonin active medications with the triptan, that you're going to get potentially that clinical triad for serotonin syndrome: cognitive, neuromuscular, and autonomic dysfunction, right? I would know those, and I would know which medications could cause, and there they are, right? It's all the ones I just mentioned, but it's broken out for you. So things that inhibit serotonin reuptake, SSRIs, TCAs are in bold, so those are your most common players. And then the MAOIs, amphetamines, and once again, the triptans, which is why we're discussing it. What do we do? You've been told what to do, hopefully, for serotonin syndrome. Like get rid of the serotoninogenic active medications. Supportive care, treat the hyperthermia, treat the tachycardia, get them cooled down. Benzoids a lot of times for anxiety. And there is a specific antidote we can give, right? The cryoheptadine on the bottom left, the periactin. And then we often put a first generation antihistamine on board too, like diphenhydramine, good old Benadryl. So just, I want you to know that the signs and symptoms and the big players that can, with triptans, can lead to serotonin syndrome. And I'd be able to know what the medication there that's specific to being able to help reverse the serotonin syndrome. Here's a combination, sumatriptan and naproxen. Pretty good deal, right? It's now we get an anti-inflammatory effect, and we get those serotonin receptors activated. The cheap, poor man's way to do this is just give them a triptan, sumatriptan, the rapid actor, and naproxen. You don't have to get the Trexamet, right? Because we already said you can combine them. If they're on NSAIDs and it's not doing everything we want it to do, we can add a triptan, or vice versa. Well, here's a solution together where you can get the anti-inflammatory effects of the NSAID and the triptan. And in this case, for the Trexamet, it's sumatriptan, which we already said can be one of our fast actors. But you can, DIY this one, prescribe naproxen and prescribe sumatriptan. right, if you don't have Trexamet in your formulary. And just in the middle there, it's just talking about what each drug does, and we've already talked about what each drug does. Don't need to know the dosing. All the studies say combining them gives superior relief to either one alone, so probably a good deal. Now we're to the ergotamines. Thing of the past, they are last. Lots of side effects with the ergotamines. Before triptans, this is what had to be used, but we're going to talk about why they're gone, right? They're not completely gone. There's some specific niche utilizations, but for the most part, we avoid ergotamines. They were the first drug that were migraine specific, but the triptans pretty much replaced them. The side effect profile being the reason. Potent vasoconstrictors. Potent vasoconstrictors. So those contraindications that we gave you for triptans, they're worse at it, right? They vasoconstrict stronger than the triptans. We will, with these drugs, sometimes combine it with caffeine. That increases the bioavailability of the ergotamine. Rectal is better than oral. A lot of oral side effects with this medication. They're less effective than triptans, but you still will see folks that used them in the past, that like them, that use them. I can tell you I've never written an ergotamine. Adverse effects. So bad it has its own name. Ergotism. If it's so bad that it has its own name, that's usually not a good look for the med, right? Intense vasoconstriction, peripheral vascular ischemia, possibly gangrene. I'll keep my headache, right? No thanks. I don't want the gangrene. Possibly tonic-clonic convulsions with mania and hallucinations. Headache is sounding better than all of these adverse effects to me. Severe cerebral vasoconstriction. Long-term use causes fibrotic valve thickening, aortic and tricuspid, and a severe precipitator of the medication overuse headache. Contraindications, anything related to vascular, right? So CV conditions, peripheral vascular disease, coronary artery disease, hypertension, liver issues, kidney issues, and guess what? Yeah, don't use it in pregnancy. For the triptans, sumatriptan's the most studied for pregnancy. Generally okay, if I didn't mention that earlier. For pregnancy, sumatriptan, generally considered okay. Ergotamines, never. And don't use it with a strong CYP3A4 inhibitor, those azoles or those macrolides. Or 24 hours of a triptan, unless you want to get the gangrene faster, right? Because now you've got severe with moderate vasoconstriction together. And that puts us at like 50 minutes, right? So why don't we take a break? We'll come back and get finished up. We go really deep into migraines, and then the other two are pretty fast. So on this slide, someone pointed out, a couple of people pointed out, there's an error. For the triptans, contraindication, pregnancy, triptans are generally considered safe in pregnancy. So it's a relative contraindication. They're generally safe, so I would just cross that out. Specifically, sumatriptan recently has had lots and lots of trials and data on it that says it's safe in pregnancy. So sumatriptan being the best in pregnancy, but it is not considered a contraindication anymore for pregnancy to utilize triptans. Everybody tracking that? Triptans okay in pregnancy. Juniors, you got it over there? Good deal. Let's get to where we were. All right, so, ergotamines, not quite as severe little brother, right? Dihydroergotamine, but the same contraindications, right? A little bit less of the vasoconstriction on the arteries than ergotamine, but still a potent venoconstrictor. So sometimes we will use dihydroergotamine for refractory migraines. They've been around for or non-refractory migraines. They've been around for 72 hours. You will see often in the ER the dihydroergotamine used IV for those migraines that are long lasting, that are not responding to treatment if they're severe. So the term is status migranus, right? So it's refractory migraines. So that's really the only utilization I've ever seen with dihydroergotamine. But still the vasoconstrictive contraindications. Slightly less vasoconstriction, as I said, slightly less nausea and vomiting than the ergotamine as a side effect. You still can get the ergotism, you can still get the fibrotic valve thickening, and it also precipitates MOH, medication overuse headache, like ergotamine. All of the nasal sprays can give you, no matter which medication, we talk about them in osteoporosis, we talk about them in migraine. So anything that's nasal can give you a funky taste, right, as an adverse effect. Taste disturbances or rhinitis. Same contraindications as ergotamine. Nothing new there. Still, unlike the triptans, no use in pregnancy, right? Pregnancy risk X. And same drug interactions, not within 24 hours of ergotamine or a triptan, and also not with those strong CYP3A4 inhibitors. So some miscellaneous agents for migraines. The butorphanol or Stadol IV or nasal. Once again, this is a controlled substance. Mixed opioid agonist available in a nasal spray. It's kind of similar to tramadol, which y'all learned in depth about like last block, right? This is your last option for a migraine, right? Last resort for an intractable migraine. High potential for abuse, it's a controlled substance, and high potential for medication overuse. Headache, I put it on there because you may see it out in the wild, but this is your last option. A mixed opioid agonist. It has some first line use, but that's in labor pain if you can't use an epidural. Off-label use for migraine, last resort. So be aware of it only. So we said nausea and vomiting is very common in migraines. So what antiemetic do we use? Usually a dopamine antagonist, Reglan, metoclopramide, first line. I would know that. And what is the adverse effects? They haven't changed since we've talked about them in numerous classes. EPS, right? Because they're a dopamine antagonist, you can get those extrapyramidal side effects. And we remember what those are, right? Those abnormal movements, unwanted, lip smacking, facial muscle movements. So EPS, adverse side effect. Some folks will say that you can use for migraine Reglan alone, but normally we're not going to see that. We're going to see it in combination, treated, used for the nausea and vomiting as an adjunct to whatever you're using for your abortive treatment for the migraine. Usually not alone. Not alone. You also have a couple of other options, right? The typical antipsychotics, chlorperazine and chlorpromazine, so compazine, thorazine, those are second line. But the Reglan metoclopramide is the big player for anti-nausea and vomiting in migraines. And there's also a third option, which is the 5-HT3 antagonist, unlike triptans, which are 5-HT3 agonists. So that's your Zofran. But there's contraindications because guess what Zofran has an adverse effect of? Headaches. So that's why it's third line. So using a nausea and vomiting anti-nausea or antiemetic for a migraine headache when it has an adverse effect of headaches is not your first go-to, right? So be aware of what your first line for N and V associated with migraines are. And the significant adverse effects, which this should be a repeat. You should have heard of it a few times with the dopamine antagonist. I know you got it in the GI portion of Pharm. So now on to prophylaxis. Prophylactic therapy indicated for patients who have frequent headaches. You need to know the numbers on the bottom right. For migraines, greater than 4 headaches a month or greater than 8 headache days per month. Why those two numbers? Because 4 headaches a month, or some headaches may last more than a day. So if you have 8 days of headaches a month. First line agents are on the top box there in bold. CGRPs, as I mentioned, show up as a potential for prophylaxis. For all of these medications, whichever you choose for migraine prevention or prophylaxis, usually you're going to base that on their comorbidities, right? If I have a patient with migraines that they're having over that threshold of 4 a month or 8 headaches days a month, but do they also have hypertension? Then maybe I'll use something in that box that's better for hypertension. Or do they also have comorbidity of depression? Then maybe I use an antidepressant from that list. Propranolol is the number one you're going to see, right? A beta blocker. I think it's third down on that list. You'll see it first on the next. Number one prophylaxis treatment usually is propranolol for migraines, right? That's the go-to. There are some contraindications, right? Asthma being a contraindication to propranolol, because it is a beta blocker, non-selective, beta 1 and beta 2s. But I would know that propranolol is the number one considered first line without contraindications for migraine headache prophylaxis. The others have their use depending on comorbidities. And then we're going to talk about CGRPs in depth. ARBs are on the list too, the candesartan, telmisartan. They're still considered, everything in the dark outline is considered a first line choice, but based on comorbidities. Propranolol is what you're going to see on boards often as the first line choice. Generally, we're getting into a little bit of patient management, but for prophylaxis, you start with the first line, and then you titrate it up 2 to 4 weeks until you get max dose. And if that doesn't work for a month or two, then we're going to switch to another first line option. I'm not going to ask you about clinical management, but just so you know how we manage patients on their initiate, and then when we decide to change or that it's not effective. So still talking migraine prophylaxis. I can tell you that most patients with migraines need it. Most patients with migraines do not get prophylaxis. So this is something you can do as a clinician to affect someone's life, right? Because if you're having more than 4 migraines a month or 8 migraine headache days a month, and you can be put on a medication to keep, even if you decrease it by 1 headache a month or 2 headache days a month, that's important to your patient, right? So 38% of patients with episodic migraines would benefit. So almost 40% would benefit from prophylaxis migraine treatment. Less than 13% of those patients actually get it. So here's where you can affect change, right? When you get that patient coming in with the chronic migraines, don't just treat them and get them out of your clinic, right? Treat them and get them out of your clinic, but make them a follow-up when they're not having a migraine to discuss prophylaxis if they're meeting that threshold for chronic recurrent, right? All right. So we all know why it works, because we discussed it early. It's the second goal, not just to get them out of pain within a couple of hours, but to prevent having to use those abortive agents, to give them more headache-free days, right? Return some quality of life for chronic migraine patients. And keep from getting migraine overuse headache or medication overuse headache from the abortive agents, because you have them on a prophylactic agent and they're not just popping the abortive agent numerous times per month. And there's the indication again. Like I said, those numbers are important. The board loves those numbers for migraines, for prophylaxis. Indications for when to go on a prophylaxis migraine medication. So we want to start low and slowly titrate up with migraine prophylaxis, right? Until we start to see some therapeutic effects, or we reach max dose on our first line. And then once again, this is in clinical management, but if we're max dose and it ain't doing its thing, then we switch to another first line. Or the adverse effects become so severe before that happens that adverse effects obviously based on which drug class that we chose out of those first line options. For prophylaxis, can take up to 6 months for full effect. And then I gave you those clinical kind of caveats for how we start, and then when we decide to change. I'm not going to ask you that on the test. That's more clinical management. The PANCE might, right? But I'm not going to ask you specifically. Neuro is going to talk more the clinical management of these migraine cases. An important caveat: if the prophylaxis works for about 6 to 12 months, slowly titrate them off, see how they do. Try to get them off that medication as well. And then doing all of those lifestyle things, right? Diet, exercise, cut back on the alcohol, cigarettes, caffeine, all the goodness in life. So considerations, like I said, first line agents, this is the same slide, just presented a little bit differently. Propranolol is usually the traditional option. Antidepressants, amitriptyline is up there, anticonvulsants. Often comorbidities is how you're going to decide which medication to use. But you can see propranolol is first on the list, and it's in bold. And then the venlafaxine is second line down there, and I pointed that out because I think there was some confusion about that being a first line or second line last semester. So I just made that note. Hey, you see it's on second line, it's over on the right. And we're still talking migraine prevention, right? Beta blockers, excellent first line, but contraindicated for your folks with asthma or COPD or a heart block. And the folks in this room haven't had the cardiac meds yet. The juniors have, so we will talk about in block 4 in 2 weeks from now, beta blockers and where they act and why that will be contraindicated in asthma. So at this point, just know that the contraindications would be asthma, COPD, or a heart block. But it's your go-to first line for migraine prophylaxis. You don't need to know all the adverse effects there. That's more clinical management. So I just wanted you to have a thorough list. And now we get into the monoclonal antibodies, the MABs, right? The calcitonin gene-related peptides antagonists, the GPANTs, or the monoclonal antibodies. They're two different things. People often link them together. So the monoclonal antibodies end in MAB, right? Those are injectables. They're larger molecule. And then we talk further down on the list, and we just choose one here, like the rimogepant. The rimogepants are small oral molecules. That's the only real difference. They're both the CGRP antagonists. So remember we said CGRP is that peptide.
So just in case you hadn't figured it out, the juniors can't hear.
Great.
All right, am I back over there? Batteries died.
That's like grade school, right? Bus doesn't show up 15 minutes.
All right, moving on. We good over there?
Yeah.
Juniors? All right, I can hear myself in here. Okay, so CGRPs, right? I said there's two different ones. There's the small molecules, which are oral. Those are the GPANTs, right? So if you see the suffix GPANTs, those are the small oral molecules of the CGRP antagonists. And then the MABs are the monoclonal antibodies, which means they're injectable. So you just need to know people refer to them as the same thing, so I point that out, just that they are actually two different things. One's an injectable and one's an oral pill, but they're both CGRP antagonists. And once again, you can pick them out of the lineup, right? Because the monoclonal antibodies end in MAB, monoclonal antibody. And then the GPANTs, like I said, NGEPANT. So when you see those two suffixes, you know we're talking CGRP antagonists. Yes. Yeah. So he's crossed out on purpose. You don't have to worry about that medication. But all of these, I'm not going to ask you, just like we talked about last block, I don't need you to memorize every CGRP antagonist. You need to be able to pick them out of a lineup. And the board's going to ask you the same thing, right? So how do we do that? I just went through it, right? MABs and GPANTs. Those are your CGRP antagonists. And the the DOD and the VA, they strongly support CGRP antagonists for prophylaxis for migraines. So they're ahead of the curve on that one. This is everything I just said on one slide, right? So when we have the trigeminal vascular system aggravated by a trigger, remember when we on that I don't know what that is, it a fox that was spinning around on the top left of that slide? We talked about a trigger. We talked about what those were, and then we talked about what it causes is the release of those inflammatory markers, one of them being CGRP. It's a vasodilator, pro-inflammatory vasodilator. And then CGRP antagonists, they block that, therefore decreasing inflammation. And they also vasoconstrict to counter the vasodilation caused by substance P, CGRP, right? So I think we've thoroughly kicked that horse. We're all tracking what they are. And once again, two different options, monoclonal antibodies, in MAB, they're injectable. It's like monthly or quarterly. And then the other are oral pills, right? The GPANTs. And if you fail one as an anaphylaxis or as a prophylactic use, you can move to another. And here's just a chart of them. Interestingly, the last one on the list, the Emgality, migraine prophylaxis, but we can also use it in an upcoming medication or a class we're going to talk about, the cluster headache here soon. I bring this up. It's not really medication, but there's a protocol for using Botox for migraine prophylaxis. It's like 31 injections. DOD does offer a class in it to you folks. I didn't get it back, before I retired, but apparently now you can get certified in doing it. Bring the patient in. It's 31 spots. I'm not going to worry about the dosage and all that good stuff. Just know, and it is on the PANTS blueprint and the PEA blueprint. Botox as a prophylaxis. Apparently, it works really well. So definitely something you can recommend to your patients, or you can get trained in and learn how to do it. Right? Probably this is happening more in room or pain. Yeah. Okay. Should be, but if not, be aware. I'm not asking you anything on it. Yeah, but be aware, because this is something that could potentially help your patients, right? But it's a drug, but it's not a drug, so it's not really Pharm, it's a procedure. Just like somebody asked me about the hyaluronic acid injections for OA. Yeah, they're there, but is that a drug? No, that's why I didn't bring it up. You'll get it in ortho, right? They'll probably talk about the injections for osteoarthritis. Same thing here. Know about it. It may come up something good for your patients, right? But it can be used once again in prophylaxis. I'm not going to ask you about the indications, contraindications, all that good stuff, right? So now we're down with migraines. Next two are pretty quick. Nowhere near what migraines lectures about. So tension, most common. You see the prevalence there, more females than males, 20 to 50 years old usually. 60% have a functional impairment. Basically, these are headaches that are thought to come from myofascial origin, right? So tension kind of makes sense. This is the most common type, as I mentioned. Often, pathognomonic, like board is going to say it's a bilateral hat band-like distribution of pressure So hat band, i.e. around the circumference of the top of your head. Not usually disabling, not worsened by routine activity. They're not going to be, laying in a dark room. They're just going to have a lot of bilateral, like I said, head pain circumferentially. They're non-pulsating, so kind of opposite of migraines in most ways. They're non-pulsatile and they're bilateral, which we talked about migraines being unilateral and pulsatile. So a lot of times we see muscle contractions, head and neck being a major factor here. But the big differentiator here is bilateral, dull, non-pulsating is tension. And then that's easy to differentiate between the migraine and then the third class, which is the worst, going to present very different in a cluster headache. Straightforward. Pharmacy for a tension headache. Analgesics, usually OTCs, right? Analgesics, NSAIDs, Tylenol, dealer's choice. Once again, we limit those NSAIDs to less than 15 days a month to prevent MOH. Just because we're using it for a different type headache doesn't change the frequency of the same drug, because the drug doesn't know if it's treating tension or migraine. So same MOH cautions, more than 15 days a month with the NSAID. Consider prophylaxis if you have tension headaches more than 2 times a week, or if it lasts quite a while, or if it's very severe, right? So just like we have prophylactic treatment in migraines, we have it in tension, but the good news here, you need to know one drug. And it's on the slide. Prophylaxis for tension is amitriptyline, tricyclic antidepressant. Don't worry about dosing. Adverse effects don't change because it's being used for tension headaches, right? It's still anticholinergic side effects. Weight gain, orthostatic hypotension, arrhythmia concerns. You'll see amitriptyline and nortriptyline in this class. Nortriptyline may be your less sedating option. But know that amitriptyline Elavil is your prophylactic drug of choice for tension headaches. There's some others at the bottom, limited data, so I won't ask you about that, right? Easy for tension, straightforward. Now we move into cluster. Not well understood, cluster headaches. Consider, arguably the worst pain that a human can have. Like, I've heard it described that way. This is the worst pain I could have ever imagined in my life. A cluster headache. Often will occur at night, and it can come in clusters, right? It can come and you can have them for a while and then they go away, or it can come and stay around for a long time, then go away, or it can come, go away, come, go away, come and go away. That's why it's called a cluster headache, right? A lot of times the first time or subsequent headaches that are cluster headaches going to start at night. So we think it's related to a circadian rhythm, but that's just a thought process, right? And we also suspect some type of genetic role for cluster headaches because of the bottom slide there, right? 14-fold increase if a first-degree relative has a history of cluster. Most severe, as I mentioned, excruciating unilateral periorbital, meaning around the eye, and temporal, around the temple, associated with autonomic symptoms, lacrimation, rhinorrhea, conjunctival injection, ptosis, and meiosis. Anybody heard of a syndrome that presents the same? Have you heard of Horner's syndrome? Ptosis, meiosis, anhidrosis, right? So think of that when we think about a cluster headache. So everybody knows what those things are, right? Ptosis, meiosis, so constriction of the pupil, anhidrosis, not sweating on that same side. And then what's the ptosis? Drooping of the eyelid, right? Drooping of the eyelid. So drooping down. All right. Unlike migraines, you need to know this patient is not lying quietly in the room. They are rocking. They are moving. They are pacing. As I mentioned, arguably the worst pain a human being can endure. I'm sure folks would argue, but that's often how you would hear it described. But just know you have those autonomic symptoms associated. Most severe, and it's named because the headache pattern. So if you think cluster, it comes and goes in a cluster. and then you'll remember it. Usually at night, as I said, episodic, can be chronic 10 to 15% of the time, can last like for a year and then go away forever, or it can last multiple years. And there's a prevalence, you don't need to know that. Usually a couple of weeks to a few months. That's a big range, right? Oh, I have this worst pain I've ever felt in my life. It only lasted a couple of weeks, or it lasted, a quarter of a year. Big range. Spring and fall, often. You can have migraines associated with a cluster. Sounds like bad news, but it can happen. And then I mentioned the autonomic nervous system findings, signs and symptoms. These patients are sitting, rocking, clutching their head, or they're pacing, holding their head. They are not lying down in a dark, quiet room. Opposite of migraines, right? And then they can go into remission and it not happen for a couple of months and come back in a cluster, or it can be like 20 years, right? So average is about 2 years for cluster headache patients. How do we treat them? Oxygen. First line, 100% non-rebreather facial mask, 7 to 10 liters per minute for about a half an hour, 15 minutes to a half an hour. Generally no adverse effects. This should be easy to differentiate the abortive therapy of a cluster headache from migraines and tensions. Medication, first line, if we're going to use one, good news, it's the same as migraine, right? It's a triptan, but it's sumatriptan. Why? Because we can do the injection or the needleless sub-Q injection with the Pro needle or the Pro delivery system with sumatriptan, and it's fast acting. If you do the nasal spray of sumatriptan, opposite the side of the autonomic signs and symptoms. So ptosis, meiosis, anhidrosis on the left, put the nasal spray on the right. That's just FYI. And then, but usually oxygen first line, and then, like I said, if we're going to use a med, sumatriptan. The ergotamine derivatives, right? As I mentioned, that's really the only indication. Besides those status migrainous patients, we can use the ergotamines in cluster. And that's what's in that box under last line. So it's not our first go-to. But often you'll see this, once again, like status migrainous, the IV DHA, because remember it has less ergotism than the ergotamines used for cluster headaches. And last but not least, I mentioned, I think, on the one slide that one of our CGRPs can be used, only this medication, the Emgality, for cluster headaches. And it's a MAB, so it's a monoclonal antibody, injectable or oral, injectable, right? All right. Once again, just like tension, one prophylaxis medication option, verapamil, calcium channel blocker. You'll learn about it in block 4 of Pharm 2, right, in a few weeks. It's used for blood pressure, angina, heart rhythm disorders, but you just need to know verapamil, drug of choice for prophylaxis in clusters, in cluster headaches. Sometimes we'll add steroids on board too. But verapamil is your go-to, Kalen is your go-to prophylactic treatment for cluster headaches. Lithium can be used, but there's all kind of monitoring therapeutic windows. We all talked about lithium as Captain Lane talked about lithium to you already, so we all know about the therapeutic index and the monitoring, so it's not your first line. Verapamil is. And then you can add on the lithium with verapamil, and you can add on Topamax. Different than some of the other prophylactic treatments, you do your prophylaxis treatment for a cluster while they're actively having a cluster headache. You get so they're having it, do the oxygen or the sumatriptan, but they're still having headaches, you go ahead and get them started on the verapamil and adding one of these possibly or steroids. And then there's a little bit of information about the Emgality down below. You don't need to know the dosing, but that's it for the cluster prophylaxis. And that brings us to the memory jog, which, as I say in all the lectures, they're a good starting point for your studying. I'll have them at the end of every one, but don't just memorize what's on the slide. If it says this class, well, you probably need to know what drugs are in that class, right? That kind of thing. So it's not like the test questions, it's a concept to trigger you to go back and look at that bit of information on the slide deck. I'll be here for a few minutes before I head out, which actually I think I'm helping out with the next door. You're having ortho lab next, right? Yeah, so I think I'm helping out over there. So if you have any questions, junior classroom, I'll be over there in about 5 minutes or so for that lab, so you can ask me then. But I'm up here for anyone else that has any questions of me.